Dear colleagues, I want to express my warmest greetings to all the participants of the conference. And I want to thank you for the opportunity to present our experience of studying the engagement and burnout among family members of patients with alcohol and opioid use disorders patients. Let me introduce myself. My name is Alexandra, and I'm a clinical psychologist working in the National Research Medical Center for Psychiatry and Neurology named after Bekhterev. My co-author is the head of laboratory of clinical psychology, Victor Bocharov, and a significant part of this presentation will be devoted to the general theoretical and methodological aspects of studying the psychological issues arising in the families affected by addictive disorders. It is necessary for understanding the reasons why we choose the burnout concept as a theoretical framework for our investigations and also for subsequent interpretation of the results. Addictive disorders are chronic diseases which often significantly undermine the addict's physical health and can have severe psychological and social consequences both for the patient himself and for his social cycle. Family members interact with addicts to varying degrees depending on their position or role in the family. They usually make a lot of attempts to help patients to cope with the disease, and the most involved relatives, who are frequently women, experience greater impact. Although family members are frequently an unpaid and unconsidered resource providing health and social care to their substance misuse relatives, problems, feelings, and needs of this group of people were out of sight for too long. This led to methodological deficit in the field of studying the psychological issues arising in families affected by addictive disorders. Based on the literature review and our own clinical experience, we explored some methodological issues concerning investigation of the informal caregivers of family members of patients with addictive disorders. And in our opinion, there are several reasons why the contributions of the family caregivers is frequently underestimated. First of all, it is stigmatizing attitude to the relatives as dysfunctional, codependent, or not more than just passive recipients adjusting to the stressful and challenging circumstances. Focusing solely on the destructive elements of informal caregiver, addicted patients' relationships dynamics are also play a significant role. Underestimation of relatives' active role in the transformation of the environment, their willingness, experiences, and knowledge in care of their addicted family members, and failure to recognize their right to participate in treatment decision-making, as well as the lack of specialized tools for assessing addicts' relatives' personal activity during the patient's care, or the consequences of their failure in maintaining patients' well-being, also playing an important role in this deficit. One of the important methodological principles currently explaining the psychology of informal caregivers is the concept of burnout. It's not only applied to the occupational context, but also used in a wide sense to describe caregiver care recipient relationships. Such phenomenon as increasing indifference to the outcomes of the disease, the sense of one's uselessness and helplessness, and decrease of vital energy, in our opinion, should be understood as the result of long-term ineffectiveness of the work of an addict's informal caregiver to overcome the disease of the loved one in a stigmatizing environment. These days, when researchers are assessing burnout among family members caring for chronically ill relatives, the vast majority employ adopted versions of Maslach burnout inventory or the Shurim-Melamed burnout questionnaire. Both questionnaires were originally aimed at studying professional burnout. MBI is called the gold standard. It is based on the three-dimensional concept of burnout, consisting of emotional exhaustion, depersonalization, and reduced personal accomplishment. Analysis of measuring tools currently used to assess burnout in the field of family relationships has revealed a number of significant drawbacks. First of all, the fact that most of them were originally came from the professional area and were repurposed to be used in the field of interactions between chronically ill patients and their family caregivers. Understanding the burnout as a general condition of psyche without taking into account the causes it has resulted from doesn't enable to consider the specific features of the family relations. Direct transfer of the burnout concept and its assessment tools from the professional area to the family relationships need to be adjusted according to the different environments and relationship contexts. Secondly, the existing method of their assessment are based on the diagnosis-centered approach. The assessment score in these cases only demonstrates the summation of destructive behaviors and processes without relating them to the resources of the caregiver. And this is in contrast to the contemporary view on the concept of burnout that points to the significance of investigating the opposite to the burnout pole, so-called engagement. One moment. So we developed a specialized tool to evaluate the emotional burnout in family relations area. Apart from exhaustion, depersonalization, and personal achievements reduction scales used to symptoms measuring, which have traditionally been reviewed as emotional burnout symptoms, our measure has an extra block allowing to evaluate the phenomena opposite to the burnout. The given block includes vigor, its life force needed to take care of the ill relative, dedication, the personal value of care's own actions, self-efficacy in treatment, and the integrative scale resource, providing the fully evaluate the carer's personal resource potential. The emotional burnout block has been updated by adding the distraction. This parameter displays the processes accompanying emotional burnout. More specific, it's somatization and addictive problems. I'm sorry. Oh, I found it. These slides show scales and statements, examples of our tool named levels of relatives emotional burnout. On the next slide, you can see indicates of fit. The models found in confirmatory factor analysis demonstrates high consistency with the empirical data. This is the final model, and good of fitness tests confirms the constructive validity of our instrument. So the test showed good psychometric characteristics in terms of reliability, internal, structural, convergent, and divergent validity. And now let's move from the methodological part to the results of the research. Our purpose was to investigate the burnout and its predictors, as well as resource potential that prevents burnout among addicts and former caregivers. This slide presents the inclusion and exclusion criteria. Within the research, 297 relatives of patients with chemical addiction has been examined. We used a wide range of psychodiagnostics tools, some of which are presented on the slide. The comparative study of the severity of burnout showed that relatives of patients with alcohol dependence in comparison with the relatives of the drug-dependent patients are characterized by the greater severity of burnout phenomena. In particular, the vice of the alcohol-addicted patients characterized by the lowest personal activity resource potential. They are more often than others depreciating their relationships with patients and their personality altogether. The parents of opioid addicts have shown a higher degree of consciousness and personal meaning of their own actions in taking care of the patient. In this context, personal meaningfulness acts as a resource component of their personal functioning. As for the predictors of engagement and burnout, the set of factors determining the intensity of studied phenomenon is different in relatives of opioid and alcohol-dependent patients. Due to the limited scope of the report, we cannot present all the models obtained. Here is the regression coefficients and significance of vigor indicator in relatives of opioid-dependent patients. As you can see on the slide, the highest regression coefficient is employment status. At the same time, this parameter participates with a negative sign. It means that unemployed status determines the vital energy and willingness to carry out activities aimed at maintaining the well-being of addicted loved one. In addition, relatives' perception of their own family independence are positively associated with the energy potential of the relatives. Relatives' willingness to act is also predicted by the sense of the impact of the loved one's illness on the family relationships. It can be assumed that relatives' energy potential is largely determined by the degree of the interiorization of the traditional model of caring in the family. The subsequent feeling of vigor is affected by the level of commitment to the cultural ideas about who should bear the main burden of caring. A necessary psychological consequences of this attitude is the idea that care is fairness should be carried out by the family members who are not engaged in other primarily occupation functions. At the same time, the intensity of such an attitude is higher, the higher is the disorganizing effect of the relative disease on the family atmosphere. In the subgroup of relatives of alcohol-dependent patients, we can see the highest weight in the presented model are the indicators of depression and phobic anxiety. The depression is included in the model with the negative sign. That is, the presence of depressive experiences determines a decrease in vital energy in general and according the willingness to perform actions related to the care of the chronically ill. At the same time, the presence of severe anxiety, on the contrary, has a stimulating effect and is associated with the desire of a relative to make efforts aimed struggling the alcoholism of a loved one. Also, we can see the parameter of moral religious emphasis, which included in the model like on the previous slide. The following slide shows regression models of the exhaustion indicators in relatives of opioid-dependent patients. Here we can see a significant contribution of somatization and other psychopathological symptoms. The exhaustion in relatives of alcohol-dependent patients' relatives is largely determined by the conflict of values and feeling of inability to openly express emotions in the family. Now we will go to the conclusions. We think that application of burnout concept as a theoretical framework allows to reformulate many psychopathological phenomena described in the family members of addicts and expands the perspective of psychotherapy by giving the opportunity to conduct interventions to improve relatives' function as a caregivers. Moral religious emphasis and independence acts as predictors of most resource components, which prevent the relatives' burnout during the care of the patient with chemical addiction. Overloading with duties and conflict of values, it's contradictions between personal values and the activity performed, a feeling of lack of means acts as a factors that impair the maintenance of the constructive component of the personal functioning of relatives. And also we found some non-specific predictors like overload of duties, lack of reward, conflict of values, and some special predictors, that is the conflict relationships with a relative's mother, so the grandmother of the addict, and lack of aspiration to encourage independence of family members, such symbiotic family relations. Low treatment satisfaction also acts as a predictor of caregivers' burnout. And the adoption by a relative of traditional culturally defined role of caregiver of a chronically ill family member provides smoothing or possibly contradictions arising between the daily duties and needs of the relatives and his cost to the fight against with the disease and maintaining the well-being of the addicts. Thank you so much, and I will be glad to answer any questions if you have.